chemical stimuli can activate the nociceptors. For example, in the stomach, acidic juice may cause wound in the stomach, right? So, like we call this peptic ulcer, right? Peptic ulcer. So it's another type of visceral pain. Or an organ like an intestine or for example, stomach can be affected by spasm. Spasm can cause pain also because it has both mechanical stimulation and also it can cause ischemia. Both of them are painful. Okay? Over distension of a hollow viscus also causes pain. Right? And you know that connective tissues cover the internal organs. For example, we have pleura for lung, right? We have peritoneum for stomach, intestine. We have pericardium for heart. And there are a lot of nociceptors in these covering layers. So stretch of these coverings causes severe pain. Okay? So the location or the starting point or visceral point are these. But at the same time, we have also other tissues that are insensitive to pain. For example, the liver doesn't have so much of the nociceptors. So it's not so painful if there is damage to the liver. Or, for example, the lungs don't have any nociceptors. So you never feel pain from the lungs. The brain itself doesn't have any nociceptors. Right? So it never gets painful. But the arteries that actually provide the blood supply to these organs have a lot of pain receptors. Right? So if they are affected or if they are damaged, it's very painful. Arteries. Okay? Or the covering of these organs, again, have a lot of nociceptors. Right? So, for somatic sensation, we have high localization because receptors are distributed all over the body, and we have a lot of receptors with a small or large receptive fields. They go to the spinal cord, they go to the brain, and we have large areas of the brain for feeling the pain or feeling the pain from these organs. Okay? So, localization can happen for somatic pain. Right. For visceral organs, usually we don't have localization. Okay. So, usually we are not aware of our internal organs. So, are you aware of your heart? You know that it's beating, but you don't feel it. Right? You know that you have a very long intestine, but you are not aware of that because there is no innervation from these internal organs to the conscious areas of your brain. Right? So that's why if there is a pain in these organs, you don't feel the pain directly. But the pain is referred to some areas in the surface of the body. We call this referred pain. So, for example, the pain from heart is referred to the left arm. Right? So you can see a map of different type of referred pains. For example, from the heart, it goes to the left side of the neck and the internal part of the left arm. Okay? Pain from esophagus, again, go to the internal, to the left arm. Pain from the stomach is felt on the right side, left side, here. Okay? Pain from the liver and gallbladder, right side. Okay? Pain from the pylorus, here. Pain from the umbilicus, around the umbilicus. Okay? So, for example, pain from the ureter, around the genitalia. So, the origin of the pain is from an internal organ, but the feeling of the pain happens in the skin, in the surface area. Right? So we call this referred pain. So pain in visceral organs often is referred to an area on the body surface. Visceral pain is localized in the dermatomal segment from which the visceral organ originated in the embryo. So heart and the left arm originated from the same dermatome in the embryo. So that's why the pain is felt in the arm. Okay? So, what is the mechanism for feeling the referred pain? I don't know why these buttons doesn't work. So, the mechanism of the referred pain. So, pain from a visceral organ go to the spinal cord, through the C fibers that have the soma and the origin. Right? Fibers from somatic structure also goes to the spinal cord. They converge on the same neuron that sends the information upward to the brain. So the same neuron in the spinal cord receives signals both from the somatic part and internal organs. So the brain receives the information, right? But the brain doesn't know the exact origin of the pain. The brain doesn't know where it's coming from. Is it coming from the internal organ or is coming from the somatic part? Because the same neuron is bringing the information. But the brain attributes the pain to the somatic part. Why? Because the brain doesn't have any understanding of the internal organ. It only can understand the somatic part. So it thinks that the pain is coming from the somatic. Right? So we call this referred pain. So this is the mechanism for referred pain. And in this figure, you can also see the descending pathway for suppression of the pain. Okay? So, and I told you that internal organs are covered by some tissues, some connective tissues. And these tissues has two layers, usually. Right? There is a parietal one and a visceral one. For example, for peritoneum, we have parietal peritoneum, visceral peritoneum, and the innervation of these two layers are different. Right? The parietal layer receives somatic innervation, but the visceral layer receives visceral innervation. So pain from parietal layer goes through the somatic CNS, but fibers from the visceral layer go through the autonomic CNS, peripheral nervous system, right? So, visceral disease process often spread to the parietal peritoneum, pleura or pericardium. So, parietal pain is a sharp pain which is highly localized, but visceral pain is slow pain, which is not so localized. Okay? So, we may have, for example, a painful stimulation in one organ, one internal organ. The damage spreads to the parietal covering. So at the same time, we have two parallel pathways for the pain. Some through the visceral PNS, some other pain signals go through the somatic PNS, okay? So this makes the situation worse because the patient feels more pain and also the diagnosis of the disease is also difficult, okay? So let's see one example, appendicitis, okay, inflammation of the appendix. So it's part of the intestine. It's a visceral organ, right? It's covered by peritoneum. peritoneum has two layers, visceral and parietal. So the inflammation activates both of them. Pain fibers from the visceral layer and also from the appendix itself, and pain fibers from the parietal peritoneum. Right? So, parietal peritoneum is innervated by somatic nerves, but the appendix itself is innervated by visceral pain fibers. So this one, parietal one, goes to the segment L1, lumbar 1, through the somatic nerves, but visceral pain fibers are transmitted through the sympathetic nervous system. They go to the sympathetic chain, and from here they go upward, and they end in the thoracic level 10. So the same pain goes to different segments in the spinal cord. One is parietal, the other one is visceral. Visceral pain is dull and vague, and it's chronic and it's slow, so the quality of pain is different. Parietal pain is sharp and fast, right? And the localization is also high. So that's why the patient feels two different pains. Visceral pain is aching and cramping, and it's referred to an area on the surface, so around the umbilicus, navel. Okay? But the parietal pain is sharp and is felt directly in the right lower quadrant. So the appendix is here, right lower quadrant, right? Parietal pain is felt exactly in the area, but the visceral pain is referred around the arms. So the patient has a pain in the right lower quadrant, another pain around the arms. The pain which is felt here is referred from this appendix, is referred here. It's dull, right? And it's not sharp actually. It is carried through the sympathetic nervous system, but the sharp pain which the patient feels here in the right lower quadrant is sharp and precise in localization. Okay? So this is the basis of the diagnosis of the disease. Maybe a patient comes to you in the clinic, okay? He tells you that I feel pain here and also here, okay? So you can diagnose the disease based on the quality of the pain, the location of the pain, okay? And there are other signs, for example. So actually you will do this later in the clinic, okay? So you press the skin and release it. The release is painful, okay? So we call this reverse tenderness. Release causes pain, okay? And the pain is localized on the right lower quadrant and also around the umbilicus. At the same time, the patient may have nausea. You know nausea? Because visceral pain causes nausea. Because sympathetic nervous system was affected. Okay, pain signals, some of the pain signals are going through the sympathetic nervous system. So the sympathetic nervous system is affected, so it causes nausea, right? So, okay, so you know that thermal signals are also transmitted in the anterolateral system. I don't want to talk about it more, okay? And you know that we have dermatomes. You know this from the anatomy, okay? So this is important for answering the questions about finding the location of the damage. You should know that, for example, sacral segments of the spinal cord innervate this area of the body, so the back of the leg and the buttocks, okay? Lumbar segments innervate the anterior side of the legs and foot, okay? Thoracic levels innervate the trunk cervical levels or cervical segments innervate the arm, okay, and also the neck and the back of the head, okay? So these are very important, you will see this. And the last slide that we have for this part, for somatic sensation is this. So let's have an example here, okay? So imagine that there is a patient. He's a man, 65 years old. He has a car accident, okay? After that, the patient actually has a damage in the spinal cord at the lumbar 1 segment. You did an MRI, and you have seen that there is a damage on the right side of the spinal cord at the level of the L1. Okay? So what do you expect from this patient if you do an examination of the sensory system? What happens to the touch? What happens to the pain? What happens to the temperature? What happens to the vibration? What happens to the position? Let's start by touch. Okay, so one of you tell me about problem with touch. Do we have any problem with touch in this patient? So, damage is only on the right side. So the left side of the spinal cord is intact. Oh, I cannot hear you. Problem is in the opposite side. So there will be problem with touch on the opposite side. Same side. So who agrees with the same side? Who with the opposite side? First, same side. Then opposite side. So we are talking about touch. Touch is transmitted through the DCML system. Below the medulla, it's ipsilateral. Damage is in the lumbar 1. It's below the medulla. So everything is ipsilateral. So the patient has sensory loss, loss of touch on the same side. Does the patient have problem in hand? No. Why? Damage is in the lumbar segment, right? So below the level of the cut or below the level of the damage, there is sensory loss. Above the damage, we won't have any problem. So sensory loss is confined to the legs, right? Right leg, because damage is on the right side. This is for touch. What about position? The same. Vibration? The same. So, position, vibration, and touch are transmitted through the DCML system. So in this patient, if you do a 2-point discrimination test, on the right leg, the patient fails. Right? The patient doesn't have 2-point discrimination on the right leg. But 2-point discrimination on the left side is intact. Right? 2-point discrimination is for touch. Right? And you can also test light touch. For example, you can use a small swab, okay, and touch the patient's skin and ask him that if they can feel it or not. Okay? So, vibration. You can put a diapason, on the leg and vibrate it and ask the patient if he or she can feel it or not. Okay? So, position, vibration, touch are lost On the right side, below the level of the cut. What about sharp pain? Left side is lost. Chronic pain? Again, left. Right? Why on the opposite side? Cross of the fibers, right? So, pain fibers from the right leg come to the spinal cord, they go to the opposite side and go upward. The cut is on the right. So nothing happens to these fibers because they are going up on the opposite side. But fibers from the left leg come to the spinal cord, go to the right, then go upward. The damage is here. So they are lost. They are damaged. So pain from the left leg is not felt. So if you pinch the skin in this patient, the patient cannot feel it. Okay? So pain is not felt. Temperature also. So you can put a cold thing, a cold object on the skin, the patient cannot understand it. Right? Actually, we haven't seen the motor functions of the spinal cord. But when there is damage on the right side, paralysis also happens on the right side. Okay? So the patient cannot move the right leg voluntarily. Okay? So we have problems with movement on the same side, problems with touch, position, vibration on the same side, but difficulty understanding pain on the left side. Temperature on the left side. Itch on the left side. Tickle on the left side. Right? So this is called Brown-Sequard syndrome. Brown-Sequard syndrome. All motor functions are blocked on the same side. Pain, itch, cold are lost on the opposite side. Position, vibration, discrete localization, 2-point discrimination are lost on the side of the transection. Right? So this is because we have different pathways in the spinal cord. Some of them cross at the level of the spinal cord, others cross at the level of the medulla. Okay? That was all about the somatic sensations. Now we can start the movement. And because in your lunch haven't total part of the spinal of the CNS, at the beginning of this course, I told you that we will see sensory systems, right? Motor system and association of systems. Remember in the first session? Actually, we are finished with the sensory part. We have covered all of the things about the somatic sensation. Now we will start motor functions of the spinal cord, brainstem, and cortex. And after that, in the next session that we will have later, I will talk about the cerebral lobe, basal ganglia, and also the higher functions of the brain. Okay, so today we will start with the spinal cord and go on with the motor cortex and the brain. So, different types of movements that we have include reflexes, rhythmic movements, postural movements, and purposeful movements. Reflexes are movements that are started by an external stimulation. So, an external stimulation causes a movement that happens automatically and suddenly, and the brain only gets aware of that. The brain doesn't do anything with the movement. Okay? All of these are happening at the lower levels of the brain. I mean, at the lower levels of the cortex. Okay? So, these reflexes can be somatic or autonomic. Right? You have also autonomic reflexes. For example, you know the baroreceptor reflex. Change in the blood pressure is sensed by baroreceptors. Signals go to the medulla. right? They reach the vasomotor center, then other signals go through the sympathetic nervous system to the heart and blood vessels. They change the blood pressure. If the stimulation was loss of blood pressure or lowering the blood pressure, the activity of the heart and vessels changes in a way that they increase the pressure. If there was an increase in pressure, they work to lower the pressure. So this is a reflex, right? These reflexes actually happen in the autonomic nervous system. We are not aware of them. They are happening unconsciously. But the start is with an external stimulation, lowering the blood pressure. And here also we have external stimulation for having a somatic reflex, right? Another type of movement is rhythmic movement, like scratching, okay? It's only repetition of one movement. Walking, it's repetition of a stepping movement, right? And chewing is also a type of rhythmic movement. But chewing is controlled by the brainstem center, but scratch and walking movements are controlled by spinal. Another type of movement is postural movements. Movements that determine the position of our body. So we can be standing up, or sitting down, or lying down. Okay? So all these are different postures that we may have. So all of them are controlled by centers mainly in the brainstem, and some of them also in the cortex. But the spinal cord is necessary for that, because commands for these type of movements start from the brain, they come down through the spinal cord, and the spinal cord actually performs the action, performs the movement. Right? So spinal cord is also important for that. Purposeful movements or voluntary movements originate from the motor cortex. Then through the corticospinal tract, signals descend in the cerebellum, in the cerebrum and also the spinal cord. They go to the muscle and cause contraction. So voluntary contraction of the muscle happens. Okay? Again, for this type of movement, the spinal cord is necessary. Right? So these are different types of movements. For these movements, we need structural support. I mean, anatomy should support the physiology. Right? So, for performing those types of movements, the spinal cord has three different types of organization. They include segmental level. So, spinal cord can be considered as a pile of segments. Each segment has its own way of activity. Each segment has its own territory. We call them dermatome, right? We have propriospinal system. So different segments can connect together, but the fibers are for spinal cord, they don't go out of the spinal cord. Okay? The propriospinal system. And above these two, we have descending pathways. So we have segments that they are connected by propriospinal neurons, and they also receive descending fibers from the brain and the brainstem. Okay? So these are different organizations. Now let's see first the segments. Okay. Not to mention, any segment has white matter, gray matter. The gray matter has dorsal horn, intermediate zone, ventral horn. Dorsal horn, intermediate zone, ventral. Dorsal horn is totally sensory. We talked about this. Ventral horn is mainly motor. Right? And intermediate zone is full of interneurons. Interneurons connect the dorsal horn to the ventral. In the ventral horn, we have two types of motor neurons. Alpha motor neurons, gamma motor neurons. Right? So we have sensory relay neurons here, interneurons here, anterior motor neurons here. So this is the segmental organization of the spinal cord, right? Sensory information from the skin, joints, and muscle come to the spinal cord through the dorsal root. Remember, A beta fibers have two branch. Medial one goes upward, lateral one makes synapses in the dorsal, right? So the lateral one makes synapses here. They can activate anterior motor neurons. Anterior motor neurons can activate muscles. So they cause reflexes. They cause movement, right? So anterior motor neurons in the spinal cord have some special organization. You can see the orientation here. This is a cross section of the spinal cord at the cervical level. So fibers from here to innervate the arm, right? Motor innervation of the arm. So you can see that distal muscles of the arm, the hand and fingers, are innervated by motor neurons that are located laterally in the ventral horn, and proximal part of the organ is innervated by alpha motor neurons that are located medially in the ventral horn. So, in the ventral horn, we have motor neurons that innervate the muscles. Those that innervate distal muscles are located laterally. Those that innervate proximal muscles are located medially. Right? And the middle part is innervated by alpha motor neurons located in the middle side. Right? Flexor muscles tend to be located posteriorly. Extensors are located anteriorly. Okay, so this is the orientation of the alpha motor neurons in the ventral horn of the spinal cord. We need this. Okay, you should remember. Those that are located laterally innervate distal muscles, so they cause distal movement. Those that are located medially innervate proximal part, right? So they cause movements in the proximal part of the arm. So now this was a cervical segment. What about lumbar segment? So it innervates the leg in the ventral part. Alpha motor neurons that innervate toes are located laterally. Those that innervate the thigh and the hip are located medially. What about thoracic levels? We don't have arm or leg here. We have trunk. Yeah, we have axial muscles, paravertebral muscles, right? So, in the thoracic level, the whole ventral horn deals with axial muscles. There is no proximal distal here, right? So, this was segmental organization. Now let's see propriospinal segment organization. So I told you that different segments can be connected together by way of propriospinal neurons. So we have some neurons in the spinal cord that have their somas in the ventral horn, right? Some of them send the fibers upward or downward, and these fibers can go only one segment above or one segment below, or maybe several segments above and several segments down. Okay? So this way, segments can be connected together functionally. Let's see this one. So here you have a cell in this segment, right? Sorry, here. It has two branches, some of them goes upward, others downward, and they make synapses with only one segment up, and also one segment lower, okay? So, these are connected together. But this neuron was located laterally. Right? Can you see that? It's located laterally in the ventral cord. It means it involves movement of the distal part of the body. So this neuron connects different segments in order to control movements of the distal part of the organs. Right? But we have another neuron here located medially. Fibers go upward and downward, and they connect several segments together, and some branches also go to the opposite side and make synapses with the alpha motor neurons located medially. So all of these segments, by way of this fiber, can be connected together in order to control movements of the proximal side, proximal part of the body, and the axial musculature. Right? So this is called proprio-spinal fiber. Remember this. Neurons in this system don't go out of the spinal cord. They're cell body, and their processes are inside the spinal cord. They remain in the spinal cord, right? So, the third type of organization is descending pathway. You know a lot of them. Vertical-spinal tract, spinal tract, reticulospinal tract, spinal tract, spinal tract, and so on. Right? Generally, we can divide them into two categories: lateral system, medial system. In the lateral system, we have lateral corticospinal tract, spinal tract. So they make connections with alpha motor neurons that are located laterally in the spinal cord. But these tracts, ventral corticospinal, reticulospinal, vestibulospinal, pectospinal, interact with alpha motor neurons located medially in the ventral cord. So these tracts deals with proximal part of the body and axial muscles, right? But these systems interact with distal muscles. These systems usually cause extension, but this system usually causes flexion, usually. Okay? Another thing is that all of these fibers or all of these tracts first interact with interneurons, and then interneurons pass the signal to the anterior motor neuron. Right? So let's see. This is anterior motor neuron that innervates the muscle. For example, here we have reticulospinal tract. Fibers go first to the interneuron. Interneuron activates the motor neuron. From here, we have pectospinal, reticulospinal tract. Neurons descend in this tract, activates interneuron, interneuron activates anterior motor neuron. Right? Again here. Corticospinal tract activates interneuron, and interneuron activates interneuron. So, most of the fibers that go down through the spinal cord first activate interneurons, and interneurons activate alpha motor neurons or anterior motor neurons. There is only one exception. The exception is corticospinal tract. Okay? In the corticospinal tract, in the lateral part, because we have two corticospinal tracts, lateral, ventral. You will see that. The lateral part of the corticospinal tract has some neurons that can directly make contact with anterior. You can see here. Some neurons from the corticospinal tract go directly to the anterior motor neuron. Some of them go to the interneuron, and interneurons activates the motor neuron. But some others go directly to the anterior motor neuron. These fibers usually are related to the movement of the fingers and lips and toes. Okay? When we need precise movements of the fingers, then there is direct connections between the cortical neurons and spinal neurons without the involvement of the interneurons. Okay? Now let's talk about the reflexes. We have seen 3 different organizations of the spinal cord. Sorry, I forgot something. You have heard the word final common pathway. Have you heard of that in the neuroanatomy? No? Okay. We have seen that billions of the neurons are in the CNS. Some defending pathways from the brain to the start movement, right? But there is no direct connection between the brain neurons and the muscles. The muscle is only under the control of the spinal neuron, anterior motor neuron. So the only neuron in the CNS that has connection with the muscle is anterior motor neuron. Either alpha motor neuron or gamma motor neuron. So, corticospinal tract should activate this. Rubrospinal tract should activate this. Reticulospinal, tectospinal, vestibulospinal, all of these descending tracts should activate this neuron, and this neuron can activate the muscle. So that's why we call this the final common pathway. The pathway which is the final one, and it's common between all of the descending pathways. Final common pathway. Sometimes it's called lower motor neuron. Lower motor neuron. All other neurons are called upper motor neuron. So in the clinic you will hear this. Upper motor neuron disease, lower motor neuron disease. Right? So damage to lower motor neuron cause some symptoms, some problems, right? Damage to the upper motor neurons cause another set of problems. And this is very important to distinguish between these 2 damages, okay? So now let's talk about the reflexes. We start with stretch reflex. Stretch reflex says, if you stretch a muscle, it contracts. Only this. Stretch of the muscle causes contraction of the cells. Another word, the muscle opposes being stretched. Right? So, whenever a muscle is stretched suddenly, the large muscle fibers of the stretched muscle and also synergistic muscles are contracted. So we may have this muscle for bending the elbow or flexion of the elbow, right? You stretch the muscle, the same muscle is contracted. Muscles that do the same job also contract. So the same muscle and synergistic muscles contract. What happens to the opposite muscle, antagonist muscle? It is relaxed. So, whenever a muscle is stretched, the same muscle and synergistic muscles contract, antagonist muscle is relaxed. This is the stretch reflex. This is not a property of the muscle itself. Okay? You know, you have physiology of the muscle. You may think that, okay, this is something related to the muscle. No, it's not related to the muscle. It's related to the CNS. This is controlled by CNS. So, in response to the stretch, CNS makes some signals that contracts the muscle. Right? So, you can see the circuit. When you stretch the muscle, some receptors are activated. They send signals to the spinal cord. Some of these signals go upward to the brain, but they are not related to the reflex. Some other signals go straight to the anterior horn. They activate alpha and gamma motor neurons. alpha motor neuron goes to the spine, to the muscle, and contracts the muscle. At the end of the alpha motor neuron, you have acetylcholine. Alright? Acetylcholine is released in the neuromuscular junction. It causes opening of nicotinic acetylcholine receptors. Then we will have influx of cations, like sugar. Then intracellular calcium goes up. Then we have interaction of actin and myosin. Then we have contraction of the muscle. Right? You remember all of this. So, stretch, activate muscle spindle, signals go to the spinal cord, they activate alpha motor neuron come back to the same muscle. The result is contraction. The receptor responsible for this reflex is, so, if you cut dorsal root, for example in a cat, then it stretches the muscle doesn't contract. Is the muscle paralyzed? Paralyzed? No. Because motor neurons are intact. You only cut sensory neurons, dorsal root. Ventral root is intact, so motor innervation to the muscle is intact. The muscle is not paralyzed. It can move. It can contract. But if you stretch the muscle, you cannot see the stretch reflex. You cannot see the contraction. So this means stretch reflex is something related to the nervous system, not related to the muscle. Right? So, in the muscles, we have two types of receptors, muscle spindles, Golgi tendon organs. Muscle spindle is in the belly of the muscle. They detect length of the muscle. This is the key word. Memorize it. Length. Golgi tendon organ is in the tendon of the muscle. It detects tension. Another key word. So tension or force is detected by GTO, Golgi tendon organ. Right? Change of the length is detected by muscle spindle. So these receptors are activated when you change the length of the muscle or the tension of the muscle. Right? Information go to the spinal cord. Some of them go upward in the DCMN system. We have seen them. Some others, the lateral branch. Go to the dorsal horn, they cause reflexes. So at the same time, with only one stimulation, the brain is aware, the brain gets aware of the stimulation, and also we have reflexes. But the brain doesn't do anything with the reflex. All of them is happening in the spine. So, now, let's see the muscle spindle. Muscle spindles are receptors in the muscle, right? They are located between the muscle fibers. Okay? So, this one is a muscle fiber. This one is also a muscle fiber. There is a small muscle spindle between them. The relation is parallel. Okay? So, inside the muscle spindle, you have some smaller muscle fibers. Okay? There are a few of them. For example, between 3 to 12. We call them intrafusal fibers. These are called extrafusal fibers. So, extrafusal fibers are the main muscle fibers. But intrafusal fibers are muscle fibers inside the muscle spindle. Extrafusal fibers generate the force of the muscle. So when a muscle contracts, actually these are contracting. Right? Intrafusal fibers are not involved in the generation of the force. This was the question for Persian students today in the field. Okay? I asked them, which one is involved in the generation of muscle force? The answer was extrafusal muscle fibers, right? Okay, so intrafusal fibers are not involved in the generation of the force. So what do they do? Okay, so they are receptors, I told you. Intrafusal fibers has a middle part and two side parts. Okay, the middle area of these fibers doesn't have any actin and myosin. So the middle part cannot contract. But at the two ends, we have actin and myosin. So the two ends can contract, right? So these ends can contract, but the middle part cannot contract. The middle part serves as a receptor. So it receives sensory innervation. But the two ends contract, so they receive motor innervation. Right? Motor innervation of the muscle is important. Extrafusal muscle fibers are innervated by alpha motor neurons, but intrafusal muscle fibers are innervated by gamma motor neurons. You know, A alpha fibers, A gamma fibers. Which one is thicker? Which one is thicker? Alpha or gamma? Alpha. So, A alpha is a thicker neuron and it can send action potential rapidly, very fast. But gamma motor neurons are thinner, so they are slower, right? Gamma motor neurons innervate intrafusal fibers, alpha motor neurons innervate extrafusal fibers. So which of these fibers is responsible for contraction of the muscle? Alpha. Or the alpha, okay? So, the sensory innervation of the muscle spindle is by 1A fibers and 2 fibers. Do you remember? We had alpha, A fiber, C fiber. A was alpha, beta, gamma, and this was general classification, you should remember. And we had also another type of classification. 1, 2, 3, 4. 1 is 1A and 1B. Both of them equal A alpha. Right? C equals 4. 3 equals, yeah. Sorry? 3 equals delta. And 2 equals beta and this is sensory classification, this is general classification. Now, muscle spindle receives 1A and 2. Right? 1A and 2. 1A, 2. Right? Okay. So I told you that muscle spindle is a receptor of what? Receptor of muscle spindle is a receptor of length of the muscle. So any change in the length, stretch or shortening, can activate or inhibit the muscle spindle, right? And I also told you that muscle spindles are located between the muscle fibers. So there is 2 ways for activation of muscle spindle. The first way is stretching the muscle. When you stretch the muscle, the main fibers are stretched, and the muscle spindles that are located between them are also stretched. The middle part, which has the sensory innervation, is stretched, is activated, right? Action potentials are generated and go to the spinal cord through 1A fibers and 2 fibers. So, in this area, which is sensory, we have a channel called piezo 2. Piezo 2. It's a cation channel located in the muscle spindle. When you stretch the muscle spindle, this channel is open, signal goes into the cell is active. Right? So the channel is called piezo 2. It's located in the central part of the muscle spindle. Now, if you stretch a muscle spindle is also stretched. These channels are open. We will have receptor potential. Receptor potential converts, actually makes action potential. Action potential goes to the CNS through 1A fibers and 2 fibers, right? What else? What about if you shorten the muscle? Okay? So, in order to see what happens, you should know what is going on in the resting state, when a muscle is not contracting. So, for example, this muscle now is in the resting state. It's not contracted now. Okay? So, in the resting state, muscle spindles keep sending action potential to the spinal cord at a lower rate. So, they are always active. They always generate action potential and send them to the spinal cord. Okay? So this is like this. Muscle is at rest. These are external muscle fibers or extrafusal muscle fibers. This one is intrafusal muscle fiber or muscle spindle. Okay? The muscle is at rest. This one, the muscle spindle, sends, for example, 3 action potential per second to the spinal cord. Why is that? Because gamma motor neurons are always activating the 2 ends of the muscle spindle. I told you that gamma motor neuron innervate the 2 ends, right? So when they contract the 2 sides, the middle part is stretched, right? So they keep sending action potential to the spinal cord. This happens in the resting state. Now, you stretch the muscle. There were 3 action potential, now there are 7 action potential. So the firing rate increases. Now, the muscle is contracted or becomes shorter. Muscle spindle is released, right? Because in the resting state, it was being stretched by that gamma neuron. Now it's released. Action potential stops. So muscle spindle has 3 type of functioning. At rest, it sends action potential at a lower rate. During the stretch, it sends action potential at a higher rate. During the contraction or during the shortening, it sends no action potential. Right? So, 2 ways for activation of muscle spindle include lengthening of the whole muscle or the parent muscle, or contraction of the end portions of the intrafusal fibers. Why? Gamma motor. Get this? Did you got? No? Muscle spindles. So, these are muscle fibers. This one is an intrafusal fiber or a muscle spindle between them. Alright? This one is very sensitive to stretch. How this can be activated? The first way is to stretch the whole muscle. When you stretch the whole muscle, this one inside this also is stretched, it's activated. Another way for activation of this is that, forget this, you know that these 2 ends are innervated by gamma motor neurons. If gamma motor neurons are activated, the 2 ends contract. What happens to the middle? Stretch. like a rope that you are stretching from two sides. So the middle part is stretched. Again, it's activated. So two ways for activation of muscle spindle is lengthening of the whole muscle or activation of gamma motor neurons or contraction of the end portions. Got this? Let's get back to this stretch reflex. Okay, the leg, rectus femoris, is an extensor of the knee, right? Semi-tendinosus is a flexor of the knee, right? Another muscle which is not shown here is vastus intermedius, extensor, right? This muscle is stretched, only this one, rectus femoris. Muscle spindle is stretched. Signals go to the spinal cord through 1A fibers. They go to the spinal cord, right? Medial branch goes upward. It's not shown here. The lateral one makes synapses in the spinal cord, right? So the lateral branch of the 1A is divided into several branches. One activate alpha motor neuron to the CNS. The second one is not shown here. Activate alpha motor neuron to synergistic. Right? The third one activates an inhibitory interneuron. The interneuron inhibits alpha motor neuron to antagonisms. So, the same muscle and the co-worker are activated, they contract. The opposite muscle is relaxed. What's the result? Contraction of these two causes extension of the knee. You stretch the muscle, the knee is stretched. So this is the same that happens when you hit the knee, okay? When you hit the knee, there is a reflex movement. This reflex is called knee jerk movement, right? When you hit the knee, the tendon is stretched, the muscle is also stretched, muscle spindles are activated, they send signals to the spinal cord, signals come back, contract the muscle. Contraction of the muscle causes jerk. Right? So knee jerk movement is a type of stretch reflex. The receptor is muscle spindle. Okay, we have seen the action of 1A fiber, but there are also two fibers. They are not shown here, right? Two fibers also send information to the spinal cord. In the spinal cord, they interact with interneurons. Then the interneurons activate alpha. So stretch reflex has two parts. One part mediated by 1A fibers, the second part by fiber type 2. The part initiated by 1A fiber is faster and stronger, right? But the contraction that happens after the activation of type 2 fiber is delayed and also weaker, right? Because we have interneurons in between. So, unit break.